Good morning, everyone. Welcome to Pediatric Grand Rounds. Today it's my pleasure to introduce Dr. Rebecca Hester. She's the Associate Professor in Science, Technology, and Society at Virginia Tech. She completed a master's and a PhD at University of California, Santa Barbara. Her current courses taught at Virginia Tech are The Foundation of Social Medicine and Monsters, Zombies, and Cyborgs. Her areas of interest include global health, Latin American migration, social cultural studies of medicine and health, and critical race and gender studies. She holds multiple professional roles, including serving on the Medicine and Society Curriculum Committee and the Dean's Advisory Committee for International Initiatives at Virginia Tech. She is a senior fellow at the Center to Eliminate Health Disparities at the University of Texas Medical Branch. She has numerous peer-reviewed publications, book chapters, fellowships, grants, and invited presentations to her name. And she's the co-author of the book Translocalities, Feminist Politics of Translation in Latin America, and previously Culture in Medicine, an argument against competence. Please join me in welcoming Dr. Rebecca Hester.
All right. Thanks, everyone. I used to work at a medical school, and I'm really glad I don't, because now I'm being reminded how early we all have to get up when we work in medicine. So thank you all for coming. I'm very grateful for this opportunity. Thank you to Dr. Parmeshwar for the kind invitation. Thanks to Janie Wood for all of her help. I'm like a one-man herd of cats. She had to herd me in to get this presentation going, and thanks to the Department of Pediatrics for having me. So the title of my talk today is Cultural Competency, Cultural Humility, Structural Competency, Insurgent Multiculturalism, or What? Dealing with Diversity in Medicine. And so let me see if I can get to the screen here. So my objectives for this talk today are to give you a little bit of background on how I came to study cultural competency and then how I came to dislike it very much. I have a bit of an allergy toward it, and I'll explain why as we go through this talk. And then to go on and talk about why cultural competency has become really a really important framework, but then why we have to kind of move past the idea of cultural competence into sort of different frameworks. And I'll go through a variety of frameworks for you. And then talk about where we can end up. What is a helpful way, not just to think about cultural competence in practice, but also how medical schools, medical educators, academic medicine might teach a new version of thinking about how to deal with diversity in medicine. And then I have to give you an obligatory short quiz, and I'm sorry about that, but that's the mandate. So let me jump in. First, a little bit about me. I have spent now almost 20 years teaching, studying, and critiquing cultural competence. And just to give you a sense of where my thinking comes from, I worked at the Stanford School of Medicine for the Office of Community Engagement, and I also was part of their Being Overseas Study program to Oaxaca, Mexico for pre-meds, and I taught a class on migrant health and had the opportunity to think a lot about what migrant health means. What do we need to know? What do physicians need to know? What do aspiring physicians need to know about how to deal with diversity? I also was a faculty at a medical school in Texas, the University of Texas Medical Branch, as Dr. Parmeshwar mentioned, and was involved with a number of initiatives through what is now the Center for Health Policy, used to be the Center to Eliminate Health Disparities. I also received an NIH extramural loan grant or award for studying health disparities, particularly for studying how physicians are trained to deal with diversity. So I had a 2-year program where I was studying that at the University of Texas and looking at their curriculum. And then I have been a board member of a federally qualified health center. So just to give you a sense of the different perspectives and the different situations I've been in, so that I sort of have developed this understanding that I'm going to share with you today. And then on the right, I put a number of publications that if you're interested in learning more after today, you'll have access to these slides and you can kind of go and have a look at some of my cranky analyses. Okay, so through all of these different travels and translations of trying to figure out about diversity in medicine, the one question that has persisted for me, and I now run the Medicine and Society minor here at Virginia Tech, and it's foremost in my daily work continually is how are doctors trained to think about diversity? And so I started my research, my PhD dissertation was on Indigenous Mexican migrants living in California. And as part of that study, I was looking at how they promoted health, how they understood the body, what their health beliefs were. And something that came up over and over was that they said they went to physicians and they did not feel cared for. In a healthcare system, they felt that they were not cared for, were not treated well, were not respected, were not understood. And I couldn't understand that, particularly because they would go to the migrant clinic as migrant workers, but they would say that they come out from there and say the physicians didn't care for me, or all they did was ask for my insurance and take my money, right? And so I was trying to make sense of that. And then, so part of that big question mark for me then led me to do that NIH loan repayment project, which was to study how doctors are taught to deal with diversity. And UTMB touts itself as one of the most diverse public medical schools in the country. So I was very intrigued to study this there. And while I was at UTMB, we had what some called a border crisis, but really was just a large number of unaccompanied minors coming across the border in Texas in 2013 and 2014. So it, again, one of the questions that was foremost in my mind was, how are physicians trained to deal with this? And there were many accounts about how physicians were trying to work with children who had been detained at the border, who were in the Office of Refugee Resettlement Foster Care, or were themselves in detention centers with their family members. And I'll talk a little bit about what they experienced there. But what happened was the Texas Pediatric Association approached us and said, it appears there are some things that we need to know about these children that we don't know. And so what I'm going to talk about today are the kind of learnings that came out of that experience, where I was thinking about how doctors are trained to deal with diversity. Doctors and physicians, particularly pediatricians, were asking us for help to kind of get more in-depth training to understand this, large number of children that were coming across the border. And so the results of that will be more or less what I talked to you about for the rest of the presentation. So as I said, in 2013, 2014, there was a 90% increase in unaccompanied minors from what's known as the Northern Triangle countries, Guatemala, El Salvador, and Honduras. And during that time period, there were more than 77,000 processed in the United States. This wasn't a new phenomenon to see unaccompanied children coming across the border. Often unaccompanied minors is a misnomer, because what happens is the children come up with a family member or someone known to their family, and then right at the border, they separate, because it's understood that children, if they are separated from their family members, will often be placed in foster care faster, and then will be placed with a family, and rather than sitting in family detention and then not be placed in sort of broader society. Although there are a number of children that come across literally unaccompanied. And so of those, about 40,000 were deported, but the rest were processed through the US system. And so the question that came up then was how to deal with the cultural and linguistic differences of these children. How do we deal with them? How do we understand them? How do we communicate with them? What do we need to know? And so traditionally, the way that question is answered is through the frame of cultural competence. And here I've just put up a couple of different definitions, and it's worth talking about for a little minute what we mean by cultural competence. Generally, it's culturally and linguistically appropriate services that are respectful of and responsive to the health beliefs, practices, and needs of diverse patients. So there's a heavy emphasis on language, health beliefs, cultural beliefs. Let's see, there's the knowledge and interpersonal skills that allow providers to understand, appreciate, and work with individuals from cultures other than their own. It involves an awareness and acceptance of cultural differences, self-awareness, knowledge of the patient's culture, and adaptation of skills. And I think on the surface, these are fine aspirations, but for me, they don't really tell me anything about what I need to know or about what we mean by culture. And it assumes many things that I'll talk about that I think are flawed assumptions. But before we go there, I want to talk a little bit about where it came from, this idea of cultural competence, and why it's framed as something that we need. So the prevailing assumption around cultural competence is that we don't know about cultural others and thus need to be educated about them, that there's an assumed knowledge deficit, which if you're interested in reading my paper, again, why I'm against competence, you'll see that I think that we don't have a knowledge deficit. I think that we do know others but in particular ways. And so I think we need to ask ourselves how we know others, and if that knowledge is actually the problem rather than a knowledge deficit. So oftentimes, we have already some underlying understanding of who people are, and these kind of underlying understandings have been well documented in the literature as shaping racial and ethnic health disparities, biases in medicine, and other kinds of assumptions that come along with that. A second kind of reason why we are told that we need cultural competence is to treat people well, right? We must gain important cultural knowledge about them and the languages we speak. I'm not averse to that idea. I agree with it wholeheartedly. I just don't know what cultural knowledge means and what counts as relative cultural knowledge or relevant, cultural knowledge. And then the third kind of defined need is that conventional wisdom generally holds that increased cultural competence will lead to more humble, ethical, and humane practitioners and to therefore happier and healthier patients. I, again, am not necessarily convinced that that's the case, that if we become more culturally competent, that we will be better practitioners and that our patients will be healthier, particularly because it relates for me to the first point, which is that I think we already have some knowledges about the people that we interact with, and sometimes that gets in the way and doesn't always make us as humble or as ethical as we'd like to be. Okay, so where did this idea come from? I'm just going to talk about the cultural side of it, but not the competence side. Simultaneous to the emergence of a focus on culture was also a focus on competency-based education, and academic medicine adopted that, right? What Joseph Betancourt has called the three-legged approach, the knowledge, skills, and attitudes kind of focus. But I'm not going to talk about the rise of that pedagogical approach, just the cultural side, which is, there was a large push for a focus on race and ethnicity through the civil rights movement. There was a large focus on primary healthcare coming out of Alma-Ata in 1978. There was a focus on giving, health for all, and certainly some of the civil rights groups were participating in that. Alondra Nelson's written a lovely book about the Black Panther movement and how they were involved with trying to provide health for all for the Black community. There has been a growing knowledge of and attention to the link between social inequalities and health disparities. So the research moving since the time of the civil rights has definitely taken on board the idea that what happens in the social context definitely has embodied effects. And then in 1994, the creation of the Office of Minority Health by congressional mandate also pushed for development of capacities of the healthcare professionals to address cultural and linguistic barriers to healthcare and to really take on this idea of health disparities. And I added this book, Unequal Treatment, which is, I think, a really important book for those of you that are not familiar with it, published by the Institute of Medicine, that documents some of the race and ethnicity-based inequities within medicine. So all of these kind of issues, and there are many more, we're bringing the idea that cultural competence should really be the framework that we use to address diversity in medicine. And so what would a culturally competent framework look like in the situation of the unaccompanied minors? That was one of the questions that came up. Do we just need cultural competence training? Should the physicians that are going to these detention centers and that are working in these sort of foster care facilities, which were really kind of holding facilities, sometimes in large venues with thousands of kids in them, should they just become culturally competent? And that kind of lens would lend us to think that physicians need to know that children speak Spanish. So a culturally competent framework would say, okay, they're from the Northern Triangle. And if you're really competent, you would actually understand that, particularly if they're coming from Guatemala or Mexico, that they may not speak Spanish, that there are many indigenous languages that they would speak. And so, you would understand that and find an adequate interpreter. You would know somehow that they were Hispanic or Latinx in origin. So that would already kind of get you thinking about their ethnicity and how they might differ or be similar to Hispanic or Latinx communities in the United States. You might know about their religion, their region of origin, and you might even have some ideas about their practices around folk or traditional medicine. So a traditional cultural competency approach would sort of get us thinking about language, get us thinking about healthcare practices, get us thinking about countries of origin and ethnicity, and then maybe even foods. And so I put on the right here, things that they might like to eat. And if you come from El Salvador, for example. So this would be a sort of traditional cultural competency framework. But in general, it's not going to do anything more than help you kind of access the children's sort of what's going on with them in an appropriate language. It doesn't get you broader context. And that's one of my biggest critiques of it, is that we don't really understand much more about these children just by virtue of understanding their religion, or that that their mom might give them a tea, or, clean them with an egg, or that, they practice Catholicism or some other religion. And it certainly doesn't necessarily help us understand what's going on with them. We can communicate with them about what's going on with them, but it doesn't give us the broader picture of what's really going on with them. Some of the literature sort of agrees with my cranky critiques of cultural competence. So it has been roundly critiqued within anthropology for reinforcing stereotypes, right? Here on the bottom right, you've got the Disneyland, It's a Small World picture, because that's essentially what it's been, referenced as. It's a Disneyfied version of culture. It kind of comes prepackaged with some of the attributes that I just laid out. This is what they eat, this is what they believe, right? It's always a kind of they understanding. It fails to recognize their other identities, so it sort of foregrounds culture as this kind of nebulous framework. But it also doesn't recognize that sometimes there's not a difference in language or background or origin between the practitioner and the patient. And so cultural competence often is, assumes a kind of otherness that isn't always there. And even if people, I know a lot of white physicians that speak very fluent Spanish and that have lived in Mexico or other parts of Latin America. And so it doesn't necessarily hold up that there's all these distinctions. A third critique is that cultural competence tends to blame the victim. So there's a lot of attribution to culture. And, if this were a different presentation, I would go through a whole litany of explanations of how culture, especially the culture of others, has been blamed for a lot of their health issues, a lot of their behaviors, when in fact what we can often attribute those things to is poverty or racism, but culture gets blamed a lot. It conflates culture with race and ethnicity. Again, I have been at this for almost 20 years, and I'm not exactly sure what culture means. It stands in for so many things: for phenotype, color of skin, language, accent, food preferences, clothing. It becomes everything, such that it becomes almost meaningless. Another critique of cultural competence is that it becomes another form of detached mastery. Going back to that three-legged stool approach, students, if they can just tick the box and their examiners can say, yes, they're competent in this because they've ticked the box, then they don't actually have to engage and they don't have to continually engage in a sort of lifelong process. They can just say, yes, I'm competent X, Y, Z, right? And I think there's a no small amount of hubris in saying that we're competent in someone else's culture. And I often, if we were in person, I would turn to the audience and say, tell me about your culture. Do you feel like you've mastered it? And, do you feel like you can master someone else's culture such that you're competent in it? And oftentimes people start to kind of, look around and go, I'm not quite sure. So I think there's, as I say, there's hubris in the idea that we can master someone else's culture, let alone our own. And then finally, a big critique of cultural competence is that it may not actually work. So a lot of people feel very resentful when they have to sit through a cultural competence presentation for a variety of reasons. They don't like it. Students in medicine often call it a soft science. They think it's irrelevant, unimportant, taking time away from the real science and the real things they have to learn. And so they don't take it seriously. Examiners don't take it seriously. And even though the MCAT is changing such that it's taking on more behavioral health and more of the sort of social science perspectives, generally, if it's not examined, then, if it's not on the test, then it's not necessarily seen as something very important unless it's a personal interest. So the pushback to cultural competence, or a way to kind of push that framework, has been cultural humility. And so here is Melanie Trevelyan and Jan Marie Garcia, who are the ones that have pushed this framework and has been adopted widely. It has, in my sort of observations, anecdotal observations, it's sort of taken the place of cultural competence. People are embracing it. They're appreciating it. They really like it. I'm less enamored with it, and I'll tell you why. I love that it requires humility, right? This idea that individuals can continually engage in self-reflection and self-critique as lifelong learners and reflective practitioners. This is the piece that people usually kind of are attracted to about this concept. But for me, I'm not exactly sure what people should be humble about or what they should be self-reflective or self-critiquing about, right? So most people I know, if I were to ask them, are you racist? They would say no, right? I've looked into my heart, I'm not racist, or no, I don't hold those prejudices. And so it doesn't teach us what we should be reflexive or self-critical about, because often, again, it's like, well, I'm not like them, those, prejudicial people. And so what ends up happening is that it becomes a sort of aspiration, I think, a nice ethical way to approach someone. But then the question about what we should actually know about this other person, what we should know about ourselves, kind of falls off the table because we don't have a framework for thinking about what we should be self-reflexive about. The other thing I like about this is that one thing I do like about cultural humility, beyond the idea that we should sort of just approach every situation with a bit of humility, even if we don't know what we should be humble about, is that it asks for us to partner with communities, to join into partnerships and advocacy relationships with community organizations and community members. And I think that side falls off often in the cultural humility framework. We get into a kind of idea that it's about an individualized sort of humanitarian interaction on our part, where we sort of humble ourselves. And again, I don't think, not only do I not think that that it offers us enough tools for thinking about that, but I also think that that sort of individualized or that individual level framework does not necessarily create the kind of healthy conditions that we would like for our patients. It just creates a sort of interaction which we exercise, sort of personal ethic. So how would cultural humility help in the case of the unaccompanied minors? As I said, physicians are asked to be humble about the power dynamics in the clinic and to develop community partnerships outside the clinic. But one of the things that I think leaves undone there is how they know what the power dynamics are that they should be addressing. Where do they get that understanding of the power dynamics? How will they know what's going on? How will they know what they should be not just humble about, but advocating for? And, if you're a avid reader of the news, or if you're someone who stays on top of these things, then I think, yes, you would know. But in general, if you're someone who spends a lot of time in the clinic and you're not necessarily paying attention to where people are coming from all over the world, right now we have probably close to 80 million refugees worldwide. Almost half of those are children, but they're coming from diverse countries. So how can, if we're not staying up on the news, then we might not know what are the particular power dynamics we should be addressing or advocating against or for. Another thing with the cultural humility framework, if we run it through this unaccompanied minor situation, there's an emphasis on physicians, again, the individual level, who are already taxed, I think. This is one of the things that I talk a lot with my colleagues about, is that they're taxed with learning, doing, and responding to a lot in any context. And so asking them then to get on board with, what they should be humble about, and, to sort of be self-reflexive is like, okay, but I'm already doing the best I can with everything I've got going on. And as I said, we don't often give them the tools or the information in their training or in their practice to think about where they should be focusing their attention. So I like cultural humility for its advocacy components, but I'm not fully convinced about what it is asking of physicians. I'm not quite sure. So there's a kind of push beyond cultural competency and cultural humility to this very jargony, admittedly, kind of uncomfortable framework called Insurgent Multiculturalism. Delise Weir, who's featured here, has kind of pushed for this. And this is a way to kind of move the needle away from what cultural competence does, which is focus on the other's culture, as well as move away from this kind of individual level ethical mandate that the individual practitioner should be the one who is doing all of the kind of kneeling, if you will, and becoming humble, to focusing instead on how non-dominant groups and are related to sort of social dynamics about inequity, particularly around inequity with regard to distributions of power and resources. So the focus then shifts, as I said, from either them or me to how are systems set up such that certain populations have power, certain don't, certain have resources, certain don't. What are the resources that they have? And so insurgent multiculturalism, while it's a bulky, unwieldy kind of term, it is trying to get us to think at a different scale and about a different object of analysis or a different object of focus. And that object is really about distributions of power in society. So this then would include rituals, policies, attitudes, and protocols within medical institutions. So it's not just about the individual level practitioners, but also what are the values and what are the policies of the institution within which practitioners are working. And so it starts to reframe what the mandate is when away from culture and toward systems and structures, if you will. Right. And so, as Delise Weir says, insurgent multiculturalism can provide students with more opportunities to look at their biases, challenge their assumptions, know people beyond labels, confront the effects of power and privilege, and develop a far greater capacity for compassion and respect. These are the things that cultural competence would want us to do, what cultural humility would want us to do, but we don't yet, within those frameworks, have the tools to do it. Insurgent multiculturalism, as awful as the title is, would give us some of the tools to start embarking on a power analysis to understand where we sit with regard to this broader kind of structure or system, and to start then thinking about it, not just changing our own behavior or getting our patients to change their behavior, but changing the systems and structures that shape our behavior, right? What we can and can't do within the clinic, beyond the clinic, what the patients can and can't do once they're under our care or out in their broader lives, and to think about how those structures and systems shape both my behavior and their behavior, right, within and beyond the clinical space. So that's a very different mandate, if you will, for thinking about how we can deal with diversity in medicine. And so I want to kind of just think with this for a minute, how insurgent multiculturalism might be practiced. And if we leave aside that label, I want to talk a little bit about being an upstream doctor as a kind of way of exercising that more comprehensive structural analysis, or for thinking in a more complex way about our role within broader systems or our patients' lives within broader systems. So this is Rishi Manchada. He has a movement that he calls the Upstream Doctors. He practices in LA. And he has tried to take his analysis upstream to look at what are the factors that are making patients sick. And if you watch his videos, which I recommend watching, he'll talk about this idea that, he'll sort of give a little tale about people sitting on the side of a bank by a river and watching bodies come by and plucking out the bodies one by one. And then eventually one of the group that's plucking out the bodies says, well, who's throwing those bodies in the river in the first place? So the question then is, who's throwing those bodies in the river in the first place leads us to go upstream to look at it rather than responding once they're, already drowning or already sick. And he talks about treating a woman with asthma multiple times and then ultimately starting to ask her different questions as opposed to just, asking about her symptoms. He starts asking about her living arrangements. And in addition to, prescribing her an inhaler, albuterol or whatever, he also says, go and see someone about tenants' rights and get the mold and the cockroaches out of your apartment building. That will help you a lot. And so this is what he means by being an upstream doctor, is that we can continue to throw pharmaceuticals and prescriptions at people, but if their living conditions don't change, it's going to be very hard for us to treat them. And so he's only able to get at that because he's exercising the kind of analysis that Delise Weir is calling for, where we start to think about how power and distribution of resources impact the health of our patients. And so here, for Manchada, upstreamism focuses on power, equity, and resource distribution as a fundamental issue that's related to people's healthcare. It asks how physicians can work within the clinic and beyond to foster healthier structures and systems. And of course, it asks questions about why people are getting sick, who is throwing them in the stream in the first place, right? So there's a little kind of downstream, upstream image for us to think with. So this is, again, as I said, a very different mandate than cultural competence and very different mandate than cultural humility, because it asks us to do a different kind of analytical work, but also informs us more about the kind of advocacy work that we can do rather than just going out there and saying, well, I'm going to partner with someone. It sort of grounds our understanding of where we should partner and how we should partner. And so if we think about upstreamism with regard to unaccompanied minors, some of the questions that we would ask beyond just trying to get a handle on their health is how and why are they coming to the United States? Right? What is driving them here? And how are they coming across? So, these questions are tantamount to asking who is throwing these kids literally here in the river, right? And what happens when they get here? What do we need to know about them? And what can we do to help? And these were the kind of questions that the Texas Pediatric Association was not necessarily asking at the beginning, but has come to ask since. And not only come to ask, but come to answer. And answer on behalf of the state of Texas, but also has pushed, as I'll show you, the National Association to really start to take on this issue of immigration and to think differently about these kids. So some of the answers that we come to when we start to ask different questions, not about their language or whether they eat pupusas or whether they have traditional folk beliefs, are beyond, they sort of contextualize more than what's going on in the clinic, but helps us create a lens for understanding the clinical interaction differently. So if we start to ask who is throwing these children in the stream, what we learn is that there's a history of civil wars in Central America since at least the 1970s that were, fed by corruption, declining coffee prices, broader agricultural changes, land reform. And throughout these civil wars in Latin America, the United States has really bolstered the strongmen military leadership and has provided money and resources to essentially kill civilians. And what ended up happening was there was a huge displacement of populations of people in Central America, many of whom came north to the United States, where they landed in places like Florida and California. And in both cases, it's a very interesting analysis if we study the difference between how Cubans were received at about the same time versus how Central Americans were received. The Cubans were treated like refugees with all the resources and are doing successfully well. The Central Americans were treated like pariahs and treated to a lot of racism and xenophobia. And particularly in Los Angeles, this resulted in them banding together against both Latinos who were already here, right? People of Mexican origin who had already been here for a long time, and other, newly arrived Asian groups and other groups, ethnic groups within the context of LA. And so this kind of bred, a defensive gang culture, which then over time was penalized and ended up with a lot of gang members in prisons through things like 3 Strikes You're Out and Proposition 21 in California, which had a gang enhancement penalty to it. And then California found itself with too many gang members in prison. And so they started deporting these kids back to, or these now adults back to Central America, a place that many of them had no memory of. And so they, we sort of metastasized the gang problem, which is what then is driving those kids to come now, because there's tremendous amounts of violence. Children are being, hacked up and delivered to their parents' doorstep in a garbage bag. I mean, it is atrocious what's going on. So the kids are coming, but we have both on the front side and the back side responsibility in the United States from a policy perspective for what's been going on, for this larger churn of bodies who, and children and families who are uprooted, come here, sent back, and then trying to come again. And so we have to think in this broader context of what these families are experiencing and what they go through to get here. And when we start to think about that, that will impact what happens in the clinic. We then have some understanding of what we should be humble about, or what kinds of questions we need to have the answers to in order to adequately treat these children beyond what they eat, or whether their grandmother cleans them with an egg or treats them with a tea. And so some of the things that we know about the journey here, this is the train, they call it the train of death, el tren de la muerte, or it's also called la bestia, the beast. And thousands upon thousands of people were riding on top of this train before they stopped it. They'd get electrocuted, they'd get robbed and raped by gang members, they'd fall off and get mutilated. Some fell under the train. Certain times the train would derail and all of the folks on top would fall off. So the journey is not easy, coming across multiple bodies of water, coming across thousands and thousands of miles on train, by foot. We know that women and girls start taking birth control pills before they make the journey. We know that they're exposed to extreme temperatures, hunger, theft, as I said, injuries and death. And throughout the process, they experience extreme terror, anxiety, and chronic stress. Many migrants show up, with nutrition-related illness, anemia. They, are dehydrated and just have this sense of anxiety. And then, on top of it, often there's family separation, not just after the border, which is what we've seen under President Trump, but before the border, where they separate so that the children have a better shot at staying in the US. And so throughout this journey, they experience all of these different conditions, and then they come to the United States, and then they're, if they're detained, then they end up in either, as I said, a family detention facility or in an Office of Refugee Resettlement foster care program. And when they're first brought in, they are brought into a processing area, which many call la hielera, which is like the freezer. You can see they're in there huddled under these blankets. And what we've seen as a result of that is that children were not meeting their developmental milestones. Women stopped lactating once they were in detention. There was significant rationing of goods and toiletries like sanitary napkins, diapers, soap. Adolescents started becoming very depressed and suicidal. And as I said, the extreme temperatures, the freezing cold, and throughout it, terror, anxiety, chronic stress. You can see children taking care of children, especially after they're separated from family members. They don't have caring adults, and the folks who run these detention facilities have said it's not my job to be their mother. I'm just here to make sure that they, get 3 hots in a cot, kind of an idea. And so, these are the kinds of contextual factors that the Texas Pediatric Association really wanted to know about. They didn't, they could say, yeah, we'll send Spanish-speaking practitioners, but they didn't have this broader picture of where were these kids coming from, what were the conditions at home, what were the conditions throughout the journey, and what were the conditions once they got here. They didn't know what to anticipate, and most especially, they didn't know to anticipate trauma. So this is a former student of mine at UTMB, who's now a pediatrician working in Seattle, and she's also a physician writer, if anybody wants to read her book or any of the stuff she's written. Her name's Rachel Pearson. And so she was one of the first people to alert me and to alert us at UTMB about what was going on in the facility in Dilley, Texas. And she was saying, these kids, it's not like a normal situation. These kids have severe trauma. And so this is a quote from an article that she wrote for the Texas Observer called, "As a pediatrician, I know there's no way to jail migrant families without hurting kids." And she's talking about the foster kids in this article, but then she links them to these migrant kids and says every single one of them, every time, is traumatized. They share this with the asylum-seeking kids whom our government has detained. Those kids were traumatized by exposure to violence and poverty at home. Some were harmed during migration. Many were traumatized again by forced separation from their parents. So this is what the Texas Pediatric Association, when we came in and we started talking to them as immigration scholars, as people who work at social scientists who work at the intersection of immigration and health, started saying, look, these are the things that you need to be paying attention to. So another one of my students who worked with me subsequent to Rachel calling attention to the situation at Dilley, this is Shannon Guillot-Wright, and she worked with me and a team of anthropologists and other folks to then start pushing for policies and practices and structures, changing structures that would improve the situation for child migrants once they came. So they wrote this report and they said, and I'll call your attention to number 2, ensuring adequate screening and treatment for physical and mental health, particularly for trauma, which has long-term health impacts on children. And so they, as a result of their work and of this growing work in our relationship with the Texas Pediatric Association, as we're sort of putting on board, this broader context for what these kids are going through, then the state of Texas convened a child refugee health cross-sector advisory board and started to really advocate for changes, particularly regarding, stopping the detention of migrants and migrant children. Not of migrants, but of migrant children, and of really trying to treat them with a trauma-informed care. So as a result, there were several follow-on documents and policies that came out of this, and I won't read them here, but they're on the site, so if you want to go look at them. And what ended up happening was the Texas Pediatric Association came out, the president of the association, Ben Raymer, who was also at UTMB, came out and said, we need to stop these egregious practices. They're hurting children. And they're traumatizing children who are already traumatized. And then at the national level, the American Pediatric Association also now came out with some statements and has a migrant health toolkit that's online for pediatricians to use. But this is all to say that a culturally competent framework wouldn't necessarily, not the way it has traditionally been practiced and understood, wouldn't get us to that point. It took a different kind of framework. It took understanding structures and history and power, right? What Paul Farmer, who is a physician anthropologist, calls pathologies of power, to kind of get us thinking differently, not only about the context for these kids, but how we should treat them within the clinic, what kind of screening tools we needed to be aware of, what kind of mental health issues, what kind of physical trauma, and how that might manifest in the development of their brain, developmental milestones, all of the things that we care about in the normal development of a child. So some take-home points here are that knowledge of language, culture, and health beliefs is not enough. Cultural competency is not enough, particularly in a context where, as I said, 40 million refugee children, that's not even counting all of the unaccompanied minor children and migrant children all over the world now. Displacement is becoming a phenomenon There are more people displaced now than at any other time in the history of the world. So understanding language and culture is not only not possible for understanding all of the diverse people coming, but it's not enough for us to really treat them competently. Self-reflexivity and humility, I think, is not enough because we don't have the tools to understand what we should be self-reflexive and humble about. So the third point I want to emphasize here is there's a need to understand and act on power differentials within and beyond the system. That is, we need to go upstream to start understanding what's going on. And we need to focus on power rather than culture in order to really be clinically competent with these children. So I've had some pushback over the years about some of my I won't call them convictions necessarily, but some of my perspectives on cultural competence. And some of them disagree with me, but some of them are really about how then would you teach physicians, right? So if I really am going to push for a kind of different perspective on teaching diversity in medicine, these are some of the things that I've heard, right? There's not enough room in the curriculum. That's always the first one. Others have said it's not my job. That's why we work with social workers or we have a team. Some say I'm not reimbursed for that. You know, I've got my 7 or 15-minute clinical visit, and that's what I get for my, clinical revenue. People have said, it's their fault for coming in the first place. I don't need to be as attentive to those broader issues. I've had physician educators say, I'm not trained to teach that. I'd love to, but it's not in my wheelhouse. Some have said I can't know everything about every group. Right, so there's a lot of ways in which trying to think of this more structural system or systemic framework is complicated for medical educators, for academic medicine. And then there's this question of how would we teach it even if we wanted to? And so if, as physician educators, as medical students, as medical practitioners, it does behoove us to think about how would we operationalize a more structural or systemic critique to move beyond this kind of cultural competence framing. And there is a movement afoot to actually ground this idea. So it's the idea of structural competency. And this is the kind of moment in the presentation where I'm like, okay, what can you do instead? You can teach structural competency. Dr. Seth Holmes, who's at UC Berkeley in public health, has called this new medicine for the inequalities that are making us sick. It's the capacity for health professionals to recognize and respond to health and illness as the downstream effects of broad social, political, and economic structures. And to my mind, it combines and applies all of the best aspects of the literature on teaching and responding to diversity in medical education. So if you're interested in learning more about structural competency, teaching it, or sort of reading up about it, here are some resources, and you'll see that Jonathan Metzl, who himself is a physician sociologist, and Helena Hansen, who is a psychiatrist, I think they're both psychiatrists, is a psychiatrist, and I'm not sure what her social science discipline is, but they're both MD PhDs, and they have been pushing for this idea to ground it in medical education so that we start to we move away from cultural competency and get to the systems and structures. Right, so here's Seth Holmes, who has a program at UC Berkeley that he calls the RAD-MED, Structural Competency Working Group. And if you went to that site, you would get access to a lot of resources about how to teach it in clinical medicine. And here also, sorry, I'll go back. Several of these articles, and you can find many more, also provide very grounded ways to think about how medical schools can take on and implement structural competency in their classrooms. So there's several examples of structural competency, but to go back to our case, physician Ben Raymer, who, as I mentioned, was the head of the Texas Pediatric Association, he basically took it all the way up to federal advocacy and said, we need to do better. We need to understand how things like public charge rules, that if any migrant accesses welfare or public services in any way, it could be held against them if they ever try to apply for citizenship, that as a pediatrician, he says, it's our job to advocate against these policies that would, prevent our patients from flourishing long-term. So this is a sort of structural competency approach, is understanding what the problem is at the structure, how it impacts health at the individual and population level, and then thinking both together and acting on both together. So I added this at the end here regarding my kind of synthesis of different approaches for dealing with diversity. Structural competency would fall in this last one where it says not cultural, not competence. So what do we call it? But there are different frameworks that I didn't talk about here. Cultural safety is one out of New Zealand. Transnational competence. There's multitudes of frameworks that I'm happy, if you ever want to know more about them, I'm happy to talk about them. But I think, as I said, doing this for almost 20 years, working in several medical schools, working with patient populations, migrants, teaching pre-med students as I do, the one that I'm most convinced about at this point is structural competency, because I think it gives us the analytical tools that we need to really understand how to treat our patients, not just clinically in the sense of, what's going on with their symptoms, but also how to understand their broader life context and how it's impacting their health. So I will stop there, and here's your quiz. Apparently you have to answer these in the chat box if I'm correct. Oops, hold on, let me go back. No, I didn't mean to do that. Hold on, get back to your quiz. And so I will look for your answers, and I'm happy to take your questions. So at least 2 approaches to dealing with diversity in medicine. Well, my prior slide, I set you up with that on purpose. Let's see if I can. So cultural competence, cultural humility, insurgent multiculturalism, structural competency, any of those were the ones I talked about within the presentation. So at least one shortcoming of the cultural competence model, I saw a couple of people said Disneyfying, but there's so many more, blaming the victim, exercising a sort of detached mastery, the idea that it sort of conflates culture with race and ethnicity. It just focuses on culture without really telling us what culture means, right? So it has this kind of nebulous understanding of culture. There's some evidence that cultural competency doesn't work, that people feel very resentful of it, or that they think it's off science. So any of those would have worked. What is one question that an upstream doctor would ask? Any of those questions that I put on the list, where are they coming from? What's driving them to come here? What happens when they get here? But really the question is, who's throwing them in the river, right? Or in the stream? Who's throwing them? What's the cause of them, drowning, or their health issues? And then the presentation has argued that it's most important to focus on which of the following, and the answer is C, learning how to understand and address power differentials within and beyond the clinic. And one of the things that I argue in my article against competence is that we need to pay more attention to the culture of power rather than the power of culture. And so for me, the shift is really moving away from culture to understanding how power works at every level, at every scale. So whether it's individually at the clinical interaction or in the broader context, because if we really truly want to take on board the social determinants of health and understand health inequity, then we have to understand power in our society: economic power, political power, social power, and our own institutional power. So those are the answers. So I'll just say one other thing about this presentation. I added all of these faces and names for a reason to the slides. So if you get the slides, you can go and find these people and see these are not the only actors, but these are actors that will point you toward actual grounded practitioners who are engaging the kind of thing that I'm advocating for. So these are, pediatricians, psychiatrists, physicians, people working in medical schools who are making the changes, the curricular changes, the pedagogical changes that will allow us to shift from culture to structures or culture to power. So that's why I incorporated all of the different, it was sort of strategic so that you have the tools to walk away from this presentation, to think with, and to look up if you need it. No, I think structural competency would precisely get to this question about, for example, one of the things that it might do is is to say, okay, what medications are you taking? What, where are you getting them? How much are you paying for them? Do you need the Walmart generics list versus, this kind of fancier, brand name pharmaceutical? Are you taking, is your sort of your folk sort of or traditional medicine contraindicated for what you're taking in terms of the prescription I'm giving you? And so understanding the broader context, where they come from, what they can access, what what they believe is important, but it also has to fit into a broader context. Can they afford it? Do they have access to it? How long does it take them to get to, if they're getting a Walmart generic, how long does it take them on the bus to get there? If it has to do with nutrition, do they live in a food desert, right? So it's not just, leave one off. It's thinking about these issues, this kind of cultural awareness. Again, I don't know that culture is the right term, but awareness of the patient's identity and practices is definitely called for. But you have to have a sense of how those practices and that identity functions in a broader context. And so that's what I'm trying to say, is we need to bring in the context. We need to bring in the systems and the structures in relation to analyzing health behaviors or health beliefs or identities. So I'm not saying we have to eschew one in order to adopt the other. And I'm certainly not saying that we just have to then become all political scientists. I'm actually saying that we just need to teach a sort of power analysis alongside what we already do. And I'll give you a specific example of that. I worked with students at the medical school in Texas who had a student-run clinic. And they were treating a lot of homeless people. They were treating migrants. They were treating a lot of poor Black community members. They had a very diverse patient population. And there was no context for them to understand the patients' lives that they were treating. They just came in with whatever they had as their own understandings of the world. And so for some of them, the clinical space in that student-run clinic actually reaffirmed the stereotypes that they had already had about homeless people, about migrants, because they had no understanding of what leads to homelessness, what it's like to be homeless, or what it's like to be a migrant, or what migrants go through to get to the United States. So they just kind of, took their own kind of world understandings and then had them reaffirmed. But then, and in a similar vein, when I said to them, you're in the student-run clinic, what do you know about the community resources? What do you know about referring your patients out if they don't have food, or if they don't have they were like, we're not taught any of that. We don't know any of that. We're not from Galveston, Texas. We don't know. And so what I'm asking for isn't to say, like, you need to totally understand, how partisan politics works. What I'm saying is that you should have a sense of what the world is for the people that you're treating. And that's very different than understanding just their culture or, your own, or just trying to be humble in the face of their difference and not really understanding what's driving the differences. So I don't, I appreciate that question, because I don't want to walk away and, have you guys go, well, I don't see the connection between cultural awareness and structural competency. Has there been any consideration to adding mission trips to help children in a foreign country to prepare for this journey to the United States? That's Victoria, that's a hard question, because there's been a lot of work actually to make potential migrants aware of the dangers of coming to the United States. There's been a ton of awareness campaigns sponsored by the US government, actually, but promoted and implemented by many of the Latin American governments from which these populations are migrating. That has been shown to have very little effect in the face of significant community violence and endemic poverty. So you can tell them all day long that they might die in the desert, but if they know that they probably will die in their street corner from gang violence or die of starvation, they're willing to take the chance. So helping them prepare, there's a lot of ways to help them prepare. But of course, that journey isn't one that anyone can necessarily prepare for, because you don't know what you're going to encounter. You don't know if you're going to encounter gang members who will, kidnap you, extort you, make you work for them, rape you. You don't know, what the temperature will be like in the desert, or what kind of coyote or human trafficker you're going to encounter. You don't know if the Border Patrol will catch you, won't catch you. So there is a lot of awareness, and certainly there's no shortage of communication between folks who've made it to the United States and the people back home. They definitely explain to them what's going on. And towns, when they get the remains of a body or hear the news about their loved ones who have been injured or maimed, or who have successfully been integrated into U.S. society, they definitely have education information. This has been going on now for a very long time. But the truth is that the desperation is so profound that even in the face of that knowledge, they're going to continue to make the trip, and there's a lot of uncertainty and precarity, even if they have all of the knowledge possible to prepare. When you're in the desert and you're thirsty and your coyote loses his way, or leaves you because you're not walking fast enough, then anything that you may have had on you, first aid kit, backpack, whatever, just gets ditched because you can't carry it anymore. It's just too much work. So yes, we could do some mission trips, but it's not going to help. What really will help is structural change of our immigration policies, change of our foreign policies, advocacy for humane treatment for all people, no matter where they come from, no matter which side of the border they live on.